Hi again.
Hi.
We're getting a little bit better at this each time, I think. I don't know, maybe worse.
In our
All
own
right,
ways.
podcast number 4, cardiovascular disease. So Dr. Green discusses cardiovascular disease and shows an interesting chart of how different diseases are recorded by country. And it's
Causes
very
of death.
shocking that nobody dies of old age in America. That's
Right.
interesting.
Nobody.
Yeah,
0%. It has something to do, as Dr. Green explains, of how their death certificates are recorded. And yet
right.
in Japan, you might have 10% of people dying from old age, not from cancer, not from cardiovascular disease, not from Alzheimer's disease. Um,
But they die of senescence and their heart eventually gives out. So in America, that's categorized as dying of cardiovascular disease. So it's
right.
interesting. And he talks in the next podcast about aging as a disease in and of itself. But I'll let you talk about the particulars. He does a really interesting qualitative analysis of his own patients across the number of years he's been treating and has found uh, very little cardiovascular events or disease, really none,
He's
none to
seen no
me,
deaths.
none that are remarkable in relation to what he's projected
Yeah,
number should be based on statistics.
right. So he's basically he's done an analysis. He's looked at his 1,400 patients, put them in different age categories, and tried to figure out based on um, rates in society, how many deaths he should have seen in those age groups over that period of 6 years. And of the 1,400 patients, he said that approximately 18 plus or minus should have succumbed and died of heart disease. And Dr. Green has not seen a patient die from heart disease or cardiovascular disease. So that's really good news. And of course, he attributes to the fact that he's prescribing them rapamycin, which has some very positive effects on all kinds of diseases. But with heart disease, it reduces inflammation, which is one of the main reasons people get heart disease and or cardiovascular disease. And yeah, he goes on to explain that and talks about some studies related to cardiovascular disease. And one of the key things that Michelle and I noted actually during the podcast is that most of Dr. Green's patients are ApoE4 carriers, so they carry one or two copies of the gene. That carrying an ApoE4 puts you at higher risk for all kinds of diseases, heart disease being one of them, Alzheimer's being another. And, Dr. Green has also said that his patients aren't getting Alzheimer's disease either.
Mhm.
And a lot of them, that's the reason they sought his therapy through rapamycin, and it's working. Apparently, it's working. So it is anecdotal, but it's a lot of patients. So
And it's based on pretty solid scientific knowledge.
right, right. I mean, while there haven't been a lot of human studies on rapamycin, they know that there have been studies on a lot of different organisms, and seems like every animal or organism it's studied in, it increases the lifespan, prevents disease by preventing disease like cancer or whatever. That's how you increase the lifespan. And health span is by, preventing these age-related diseases.
Mhm.
So yeah, without
All
further
right.
ado, we'll go on to Dr. Green and his discussion on death rates and his analysis of his patients and cardiovascular disease.
Here he is. See you later, Liz.
Okay.
Hi, Raptors.
Okay, hello.
Hi.
Today, Dr. Green wants to talk about cardiovascular deaths as they relate to rapamycin use. And also, Dr. Green, you want to just talk about cardiovascular disease in general, the mechanism. So take it away.
So let's start with that. Let's start with chart one. Two courses.
CNC chart 1. Okay.
Oh, all right. We're going to start with talking about causes of death. From the point of view of being in the of trying to extend lifespan, prevent death, it's necessary to have a good idea of what people die from. I looked at the sort of like these numbers from Japan and the United States because they're like dramatically different. One slight difference is Japan's numbers, like the best numbers I could get, were 2000 to 2019. That was before COVID. And the United States numbers were 2022, and they included COVID. But the sort of like the big difference is, it's sort of like the Japanese deaths, the leading cause of death was cancer. Cancer is a major cause of death in the United States. In the United States, the leading cause of death was cardiovascular disease. And that was the leading cause of death, and also in Japan. The difference is, in Japan, a major cause of death is Alzheimer's disease. In the United States, Alzheimer's disease is underestimated by about 8-fold. What happens with people with, and you can see they mentioned Alzheimer's disease, 3.4%. Basically, 1 out of 3 older people die with Alzheimer's disease. But these people who die with Alzheimer's disease are generally not, Alzheimer's disease is generally not listed as a cause of death on the death certificate. So even though we have around 500,000 new cases of Alzheimer's disease is a cause of death. Looks like, 3%, hardly anything. The reason how this comes about is people with Alzheimer's disease generally get admitted to a nursing home. Now they're in the nursing home for 3 to 6 months. Now they die. Well, they had Alzheimer's disease instead of admitting diagnosis. When they die, something else is the idea is, well, they were admitted with Alzheimer's disease. They had Alzheimer's disease when they came in. They had Alzheimer's disease now. They died now. They must have died from something different. So the cause of death is listed as something like COVID or heart disease or cancer or sepsis or pneumonia or bed sores. It's almost never listed as Alzheimer's disease, even though the Alzheimer's disease, once you have Alzheimer's disease and dementia, you have a very, very high rate of death compared to people with non-Alzheimer's disease. If you look at the excess deaths of people with Alzheimer's disease, it's much more, it puts Alzheimer's disease is right up there with cancer and cardiovascular disease, is the leading cause of death, which is reflected. So the Japanese statistics are a much better reflection. 3 major causes of death: cancer, Alzheimer's disease, cardiovascular disease. The other reason I included the Japanese statistics is in the United States, nobody ever dies of aging. It doesn't matter if you are 104 years old and you're in your usual state of health, and then you go to sleep that night, and then in the morning you're found to be dead. Nobody says you died of aging. On the death certificate, they write death, acute heart failure due to cardiovascular disease. Now, this is a complete myth because the cardiologists know that if you have less than 50% obstruction of your coronary arteries, it doesn't do any good to stent those arteries, Like they could put a stent in like everybody who has some degree of obstruction They don't do that because they know it's not going to increase their lifespan one day. It's not going to have any benefit unless they have a dramatic obstruction, more than 50%, 75%. They put in a stent. The cardiologists put in a stent when they know clinically that blocking the stenting a blocked artery will improve the person's situation. On the other hand, when that same person sort of like dies, even though they have the same degree of cardiovascular disease they had for the last 5 years, it's not unchanged at all. It's always listed as cause of death, cardiovascular disease. For some reason, there's the idea that no matter how old somebody is, nobody ever dies. Even if you're 110 years old, you don't die of aging. There must be something else that you had. You have cancer, you have something, you have cardiovascular disease, you have something. It's just nobody in the United States dies of aging. In Japan, this is different. They're putting down aging as a cause of death. So that's why I put in the Japanese statistics. I think these numbers are sort of like showing the 4 major causes of death: cancer, Alzheimer's disease, cardiovascular disease, old age. They're a much better reflection of what people are dying from. And if you're interested in sort of trying to prevent deaths, you want to know what people are dying from. Okay.
Dr. Green,
Sorry.
I'm wondering why the years are different that you're using the comparison.
Right. The sort of like the 2022 study was a very good study. I found listing different numbers. And the Japanese study was a best study I could find. So I couldn't get sort of like what's corresponding. It would have been better if I could have a US study 20 to 29, but I didn't find that. Now, but death certificates right down, it's kind of like very subjective. It's sort of like, I mean, I was a medical examiner for 10 years. It was my job to certify causes of death in Nassau County, 1 million people in Nassau County for 10 years. During that time, nobody ever died of aging. Right at a cause of death. But the main idea was simply, people didn't want to have an autopsy. You wanted to sort of like have something down. Cardiovascular disease was always the concern was to make sure somebody, the case was not a homicide. If the person died of natural causes and no one wanted an autopsy, you'd write down cardiovascular disease. That was listed as the cause of death. Now you have some diseases, times a person could have a very cardiovascular disease, could be a very dramatic cause of death. Somebody has a abdominal aneurysm and it ruptures and they bleed out in 2 minutes. That's a very dramatic cause of cardiovascular death. But other people with cardiovascular disease might be in their usual state of health, have no pain, no symptoms, no nothing. They just die in their sleep. They're frequently dying of old age, but no one is sort of like officially dies of old age in the United States. So somebody has to get something has to be put on a death certificate. And why people are dying of old age is very poorly understood. Although the studies have shown that the aging heart is developing more and more senescent cells and becoming more and more susceptible to fatal cardiac arrhythmias.
Right. So your heart just gives out eventually, and that's how you die of old age, right?
Say that again.
Eventually your heart gives out. So if you're dying of old age, it's really your heart that's.
Everybody of old age is generally dying of acute heart failure. So they're dying of acute heart failure. And the question is, what caused the acute heart failure? You could say the acute heart failure was due to old age, or you could say the acute heart failure was due to cardiovascular disease. But there's no evidence that obstruction of the coronary arteries is what's causing the death in people who have a mild degree of obstruction and are not having any pain.
Right. So cardiovascular disease is the coronary artery portion of what's going on with the heart.
Lots of times cardiovascular, it says convention. It's like you simply write that down as the convention. It basically means the person was not murdered and they died from something.
Yeah, that's what was on both of my parents' death certificates. Cardiovascular disease, even though my dad had Alzheimer's disease since, for about 12 years by the time he died. So, I was really surprised to not see Alzheimer's disease on his death certificate.
Usually the family has a much better idea of what the person dies from the death certificate. They'll say the person died for old age if they were basically asymptomatic and they just died in their sleep, or they died from Alzheimer's disease if they were sort of like suffering from dementia in a nursing home, or they died of heart disease if they were having pain and heart failure.
And old age, given that Japan has a really a lot of longevity or increased longevity compared to other countries. Maybe you would expect to see their old age be a little higher than in the US, but not, you wouldn't expect the United States to have a 0.0% of people dying from old age.
That is just to illustrate that. Right. I was very impressed with the fact that Japan was diagnosing people as dying of old age. And the United States, I think since 1951, they decided nobody could die of old age.
Would you say that old age could also be called like heart failure as opposed to cardiovascular disease?
I don't know that the chance numbers are different. I just was sort of like, it was just to basically show that they were having they were including Alzheimer's disease and old age as major causes of death. And I'm not sorry to differentiate these numbers. I'm just saying these four conditions are the major causes of death: cancer, Alzheimer's disease, cardiovascular disease, and old age.
Okay.
Why
Okay, so
isn't
the United
diabetes
States
on here, Dr. Green? Why isn't diabetes up there in the numbers?
Diabetes is sort of like would probably come in under cardiovascular disease. And it's sort of like diabetes is generally coming in under cardiovascular disease, strokes, kidney failure.
right, because it causes other conditions which cause you to die.
Right, it's contributing. And you could say it contributes to Alzheimer's as well and cancer.
Yeah, all of those things.
No question that diabetes is a major cause of death. It's just death from diabetes is generally listed as something else: stroke, heart disease, renal kidney failure.
All right.
Okay. So let's look at my calculations. Okay. This is a calculation that I made up. It was basically something that I would like know.
Oh, wait. Sorry. We're gonna have to cut this out, Michelle.
Okay.
I guess I can't show it as a slide. I can only show it like this. Sorry about that. Okay.
The question is, in the United States, there's no doubt cardiovascular disease is a leading cause of death. And cardiovascular disease, due to things like sudden death from heart attacks and strokes, are very, very, very real. The question is, how many people were dying of cardiovascular disease on rapamycin? Especially how many people taking rapamycin were having an acute myocardial infarction, or how many people were having a stroke? And the problem was I wasn't being told, I wasn't seeing this. If I sort of looked at something like prostate cancer, I would have a very high level of people with prostate cancer, people telling me they developed prostate cancer. And that was consistent with my estimate of how things should be. And it was clear that rapamycin was not preventing prostate cancer. But prostate cancer should have been about the same as deaths from heart disease. And I just was not hearing, people were not saying there was death from cardiovascular, death from a heart attack, or death from a stroke. And I basically have a very good relationship with my patients. I tell my patients that rapamycin dramatically prevents sudden death from due to heart attacks and atherosclerosis leading to strokes, and rapamycin is preventing that. Therefore, if one of my patients died from a heart attack or from a stroke, I'd expect to get an email saying, my husband or my wife, they died from a heart attack. I just want to let you know that because you were saying rapamycin was preventing that. Well, my husband died of a heart attack. The thing is, I didn't get any emails like that. I haven't, it's sort of like my practice started in April 2017. Now I have close to 1,400 patients. And during this time, I'm not aware of people who died from acute myocardial infarction or a stroke. So that seems very, very, very strange since this is the leading cause of death. So what I try to do here is try to figure out how many people I should have seen. In other words, how many people, was it a few people died and I just didn't know about it? Or was there a lot of people died? So I was trying to estimate how many people should have died, would be expected to die in the 6 years that I've been following them with different people in my practice from 2017 to the present. This is very difficult, sort of like estimation. It starts with trying to know, because it varies very, very much between age group. And the age has been changing, decreasing in the statistics. But I found where I thought was a very good study, and they was giving the age group for people in the 70 plus age group, and they gave it in sort of like for 2021, and the number of deaths per 100,000 population, we'll say, in 2019, should have been 2,624 in the 70 plus age group, and 370 in the 50 to 69 age group, and the age group less than 40, the numbers were like fairly insignificant. So then to try to estimate how many people should die, I sort of like was trying to estimate, well, how many people in these different age groups? In my estimation, I had about 15% of people in the 70 plus age group and 75% of people in the 50 to 69 year age group. And then I was looking, then I sort of like applied how many, the numbers from the 2624 and the 370 deaths from sort of like 100,000. Well, I was then basically reducing it from 100,000 to 10,000 to 1,000. And then I was, but basically I had to know how many people I had, basically trying to estimate how many patient years my practice represented. This was a very, very difficult estimation because it was changing every year. The first year, it was a small number. So each year, there'd be like more, and then each more, so like more. Most of the people I'd be following since they started. A few people would drop out. So then I had to estimate how many people were in each age group to try to estimate how many deaths I should have seen. This was basically just trying to come up with a qualitative answer. In other words, using these sort of like arithmetic to calculation to come up with a qualitative answer. The question was rapamycin preventing deaths from cardiovascular disease? And the calculations was like how I got the calculations is I took my sort of like about 1,400 people. I decided that like maybe half of them, if I divide by 2, that would give me an idea of the patient years I've been seeing people. And then if I had an idea, so I took the idea I came up with 4,200 patient years. And then I sort of like multiplied that by the percent of people in different age groups and what the rate of death was. And I came up with the idea that the 70 plus age group, there was 15% of practice, and their death rate was sort of like should have been around 630 deaths for 4,200 people. But based on the number of people I had, I figured I should have seen 16 deaths, and like an estimate in the age group of 70 plus. And when I should have figured, I looked at the age group of 50 to 69. I thought that was 75% of the people. I took the risk of like 370 per 100,000 population, 3.7 for 1,000. How many people I had? I came with the estimate that I should have seen 2.8 deaths in the 50 to 69 age group. I put that together, and I came with the idea that I should have seen about 18 deaths, maybe 12 deaths, maybe 25 deaths. But 18 deaths was my ballpark figure. It was definitely a significant number of deaths. The problem was I didn't see any deaths. Nobody told me that their husband or their wife died from a stroke or a sudden heart attack, and they were on rapamycin, and I said that was not supposed to happen, and what's up with that? Just wanted to let you know my spouse died.
I'd be
Well,
interested, Dr. Green, to know, I would imagine a lot of your patients are seeing you because they're at higher risk of cardiovascular disease. And maybe, do you know all the ApoB status of?
I'm talking about people who died who would have been like healthy, not people who are chronically sick and their death was expected or something like that, and so forth. People were in perfectly good health and walking around and so forth, and suddenly dropped dead from a heart attack or suddenly had a stroke. That was not expected. That I should have heard about. That was not hearing.
Right. But I know, like when you do your blood work, you have certain biomarkers that you're paying close attention to, like insulin, right? But how do you know what I mean? Like, are you following their cardiovascular markers as closely?
No, I'm following people as far as what they're having people having any symptoms, following people sort of like, cholesterol levels, following people's insulin sensitivity. I'm like treating people with my sort of like protocol. I'm just sort of like following people, and I'm sort of like talking to people every 3 or 6 months. People are sending me emails when anything new happens, when they have a question about anything. If any sort of like little thing happens, so I get an email. I have a cold, so I take rapamycin. Like any particular little thing, or should I skip the rapamycin? Any particular little thing happens, I get people send me emails. They say this, they had this result or that result. they tell me when they have a bad result. They tell me if they have this. And it's like I hear what's going. I said I like talk to everybody, but mostly I get even if I get a feedback back, it's because my patients they're extremely sophisticated group. They're very, very smart. They realize rapamycin is an experimental treatment. They realize that most of the data that there is about whether rapamycin is working is coming from my patients because I have the largest collection of people, of treating people on rapamycin. So they know that me hearing, getting feedback about what's happening is very important. So,
Dr. Green. Yep. Go ahead. Sorry. Well, my question is this. Since a large portion of your patients have either 1 copy or 2 copies of ApoE4, that's a risk factor for cardiovascular disease as well. So you'd expect to potentially even have a higher rate of death than the average population from cardiovascular disease.
Right. I think that was kind of what I was trying to get at.
Why did you say I should have a higher number?
Because you have a large number of patients who are ApoE4 homogeneous or heterogeneous.
I would imagine like half the people, that would increase the risk.
A lot. That would increase the risk a lot.
People who are double E4, they have a higher risk of coronary disease, and half the people are that. So that group of people should have a higher sort of like risk.
Right. If the risk is double, then you would expect, that half of that 18.5 to be doubled. So just for half of the patients, and half of your patient years, you would expect to see that number in homogeneous.
This calculation, I sort of like increase, like in other words, like the increased risk because people who are E4 positive. I didn't have that. I just looked at age. It's like age is the predicting factor.
But this is a conservative estimate from that standpoint.
But in addition to these sort of like numbers of people died, I did hear about people. I used to think that nobody had a heart attack under rapamycin. In the last sort of like year, I actually heard of 2 people, but they were peculiar cases. One person was somebody who had an occlusion of the right coronary artery. They didn't have any other risk factors. And they sort of like did not have any disease in their left anterior descending. They did not have any disease in their left circumflex. They just had a disease of their right coronary artery, and that was it. And I was notified that my husband had a heart attack in his right coronary artery. And I said, well, that was real unusual. I attribute it to, there was probably some kind of anomaly in the right coronary artery, in that it made a very sharp turn, creating a whole lot of turbulence. So there was some sort of like local factor related to the right coronary artery, because it was so peculiar that the right coronary artery should wind up with the occlusion and the left anterior descending should be perfectly fine. So that was like one person. But it shows that when people have heart attacks, they tell me about it. So that was like what, and then there was another person, a woman, and she had a heart attack. It was like a mild heart attack. She doesn't appear to sustain any damage. But she had all sorts of risk factors. She had sort of like intolerant of statins, so she had very high level of LDL. She couldn't take a statin. She had high levels of sort of like iron. The iron caused insulin resistance, so she had high levels of insulin resistance. She had increased her liver disease and just cholesterol. She had different risk factors, and she had a heart attack, and she got like a treatment, and she did well with the treatment. But that was like 2 people. But the idea is that they didn't die. It was a mild heart attack. But the idea is that they definitely notified me. I had a heart attack on the weekend. I just, so forth. I was notified within a couple of days. that they had a heart attack.
I would call you if I had a heart attack. I'll call you if I get Alzheimer's disease, Dr. Green.
It's
So
not-
how do you
If
think
I
that,
remember, that is.
it's just talking about people mentioning. I want to like review what we said about Alzheimer's disease in the last podcast because it was extremely important. The idea is that Alzheimer's disease, for most people, for the people who are not E4 positive, is a disease of old age. A kind of natural part of the declining of the brain. For the 25% of people who are E4 positive, it's a specific disease. It's a specific disease involving a breakdown, involving something called CYPA, which results in a breakdown of the blood-brain barrier, and rapamycin is highly specific for preventing that. And we pointed out the last time, I was not seeing any increased risk of dementia in the 704 people. The idea was that for the 25% of the population that's E4 positive, they're at risk. They're at 3 times the risk. They get the majority of cases of dementia prior to age 80, even though there's just 25%. For the 3% that are double E4, they're at very high risk. And it's something that's treatable with rapamycin because rapamycin was blocking the specific defect in that E4 was causing a breakdown of the blood-brain barrier. So that was the takeaway from last podcast, that everybody should know that if they're E4 positive, especially if they have a family history of Alzheimer's disease, and know that there's a treatment for prevention. Okay, just circling back.
so you've seen 0 deaths in your practice over
What?
these 6 years. How is rapamycin preventing cardiovascular disease and death, Dr. Green?
Good. I'll go with, that's a very good question. I went to sort of like, before I go into that, I was wanting to go into, and that's going to be a major part of our discussion. But before I went into that, I wanted to talk about the natural history of acute myocardial infarction and point out why it's something you want to avoid. Right in the United States is estimated to be 1.1 million heart attacks a year. 38% of those are called ST segment elevation myocardial infarction. So it's ST elevation myocardial infarction. Those are cases in which you have a complete occlusion of a coronary artery. So a complete occlusion of a coronary artery, that results in about 400,000 deaths. And what is the, it's like, and what is important to understand that in those deaths, most of the deaths occur in the first hour before anybody reaches the hospital. 13.6% of deaths are prior to reaching the hospital in the first hour. The next 7.5% of deaths is in the hours 2 to 24. Like that's not the first hour, but the first 24 hours, 7%. And then the rest of the hospitalization from days 2 to 28, only 3% die. So 3% die in the sort of like after the first day in the hospital, 13%, almost 13.6, almost 14% are dying in the first hour before they reach the hospital. 21% are dying in the first 24 hours. So, and the idea that 50% of the people die before reaching the hospital, it shows that acute myocardial infarction is something that has to be prevented because the first symptoms of coronary disease is frequently sudden death. In other words, death within the first hour. a sudden onset of severe chest pain, shortness of breath, pressure in the chest, lightheadedness, and the rest of the stuff that goes along with the heart attack, and a high risk of fear because there's a very high risk of death in the first hour. And so acute myocardial infarction is something that has to be prevented. A lucky group, the people who have angina, they're the lucky group. The people who have sort of like a slow occlusion of a coronary artery resulting in pain, they have angina, they go to a cardiologist, they get treatment, they get a stent put in. They're the lucky group. To sort of like what's going on in the sort of like people with acute myocardial infarction is basically they have a moderate degree of obstruction, maybe 50, 67%. And then they have a breakdown of the plaque. The breakdown of the plaque bleeds, and sort of like 1 minute, they go from having 30% of 30, like a mild degree of obstruction, not enough to a mild degree of obstruction to 100% obstruction when the sort of like plaque bleeds and causes complete obstruction. So that's the thing that's generally resulting in sudden death, or like death within the first hour. Now, getting back to your sort of like question, how do you prevent it? And how do you prevent it? That's going to be the next part of the discussion. Basically, I consider coronary disease a two-step process, an upstream process and a downstream process. And prevention should be aimed at both things, upstream and downstream. What the upstream is you have LDL, what's called the bad cholesterol. It gets oxidized in the tissues, and now it looks like foreign material. Now it looks foreign because it's oxidized, and it's sort of like the macrophages react to it. If the macrophages were dogs, they would start barking because it didn't look right. But they don't start barking. They start up a chronic inflammation. And the disease process is the chronic inflammation being caused by the macrophages who think the oxidized LDL is something foreign like bacteria, and they should try to have an inflammatory process to destroy it. But in the inflammatory process, they just wind up building more and more plaque and calcification and obstruction and inflammation and lesions that can finally rupture and bleed and cause complete obstruction. So that's the sort of like so the disease is triggered by high levels of LDL entering the tissues. The sort of like treatment is lower LDL. And right now we have extremely good drugs for lower LDL. The problem is statins are very, very good, but they could also, in a number of instances, increase your risk of diabetes by causing insulin resistance. So I would like to try to use the lowest dose of statins possible.
Among many other side effects.
Yeah, there's like they have all sorts of side effects. The side effects of muscle cramps is sort of like good because you know about it and you stop using it immediately. If you had that and you kept on using it, you develop serious muscle damage. But people don't do that. As soon as they have a problem, they stop using the statin. They stop the statin, and it clears up immediately. So the muscle cramps are okay. The problem is, just like about 25% of people get muscle cramps, because 25% of people appear to be especially sensitive to statins and develop insulin resistance and insulin resistance is harmful. The problem is, if you don't measure the insulin level, you never know that the statins is caused insulin resistance. Right now, there's two other sort of drugs that were spectacular. There's Repatha, which is looks like a new kind of drug to sort of like it's called a PC9, like
PKS.
at least like PC, like something like the PC something like K9. Like the K9 is sort of like is like the last part of it. PC something K9. Anyway, this is a spectacular drug, like Repatha, because what it's doing is it's decreasing. It's like stopping the breakdown of receptors which take out LDL. So you wind up with sort of like more receptors in the liver. So the liver removes all the LDL because there's more receptors. It's not breaking down the receptors, and that has a dramatic effect of preventing or like reducing the LDL without a whole bunch of side effects. Also, the other thing is that the other sort of like risk factor is what's called LP little a. LP little a is not reduced by statins. The study showed that statins increased LP little a by 10%. So if LP little a is high, that's an important risk factor. And that could be reduced by the like Repatha, or a new drug that's also a spectacular drug called Leqvio. That's like a messenger RNA. Both Repatha and messenger RNA require subcutaneous injections. The problem is they're both spectacular drugs and they're both really expensive. So that's
Very expensive drugs. It's called a PCSK9 inhibitor, Dr. Green. PCSK9 inhibitor. I've heard a lot about those too. I don't.
yeah.
I
So
know.
that's the sort of like top drug with Leqvio. The only problem is the cost.
They're hugely expensive. Is that also like, I think, an SGLT? I think maybe that other one is
It's like the piece
SGLT2 inhibitor. Is that the Repatha, did you say, or the other one?
it's a monoclonal antibody. I forgot the exact name of the monoclonal antibody, but it's a monoclonal antibody with reducing a thing that's sort of like removing the LDL receptors. So you have more LDL receptors. It's working that way.
Oh, okay. No, it looks like the SGLT2 inhibitor is a drug for type 2 diabetes. Sorry, I'm getting my drugs mixed up.
Okay. And then so that's one way. The upstream sort of like component of sort of like preventing coronary heart disease is reducing cholesterol. The downstream component is stopping chronic inflammation. It turns out that chronic inflammation is mostly a disease you could call of friendly fire. The oxidized cholesterol would not do anything if the macrophages didn't do anything, which is like didn't do anything. The problem is the macrophages are starting chronic inflammation, and then the chronic inflammation is driving the disease. There's a lot of sort of like preclinical studies that were showing that rapamycin would be effective. But the problem is the preclinical studies were like limited in that humans are the only animals that get atherosclerosis, so they didn't have a good animal model. But in the preclinical studies, they were showing that rapamycin was stopping cholesterol from entering the tissues. It was stopping the inflammatory process that was driving the disease. It was stopping the sort of like macrophages from having the chronic inflammation driving the disease. And probably most important, it was blocking something called MMP9. MMP9 is a thing that breaks down proteins So when you have a lot of inflammation and other chemicals, some of these chemicals stimulate MMP9, a drug that breaks down, a chemical that breaks down proteins. The protein breaks down the structure of the clot of the plaque. So if you dissolve the protein in the plaque collapses and it starts to bleed. Rapamycin is real good at preventing that. Even if you have, so it's very good at preventing the lesions from starting to bleed. So it's good from causing the lesions from building up. It's good for causing the lesions from breaking down and bleeding, causing complete obstruction. The sort of like preclinical studies were suggesting that rapamycin would be very effective in lowering the risk of coronary heart disease. And in my sort of like study, I've just been amazed as that look like that I was just saying a complete, what appears to be a complete absence of people developing fatal coronary heart disease and heart attacks being very, very rare. I mean, in other words, I wasn't thinking they're happening at all. Now I've seen two, but it's definitely no question in my mind. It's a very, very rare event. And it's having the same sort of like benefit of the sort of like of a stroke. But the stroke is different. The stroke can have a lot of different reasons. It's not stopping an emboli. The emboli is caused by it's prevented by anticoagulants, knowing that you have something like AFib. It's sort of like then you have bleeding, strokes due to bleeding, which are prevented by treating high blood pressure. But the rapamycin itself is very good for preventing buildup of the plaque into you that leads to obstructions. So it's good, it feels like good for strokes, and very good for acute myocardial infarction. The other disease I wanted to mention was gingivitis. Gingivitis is very nice because it gives people an insight into what rapamycin is doing in the coronary arteries. The idea is that there's a correlation between people who get gingivitis and coronary heart disease, but one is not causing the other. It's just a similar tendency of chronic inflammation. Now, in gingivitis, what's going on is that you have the bacteria causing the disease, but the bacteria are not causing invasion. They're not causing invasion of tissues. The bacteria are causing a breakdown of chemicals, and those chemicals are stimulating chronic inflammation. Now you have the same sort of like cells macrophages that cause coronary heart disease, causing gingivitis. And then the gingivitis causes damage to the mucosa, the gingiva, the underlying bone, the loss of teeth. So, and it presents with bleeding of the gums and tenderness and pain. But the thing of why I presenting it here is rapamycin is dramatic in stopping gingivitis. So people notice that all the patients who have severe cases of gingivitis, when they go to the dentist, instead of the dentist saying 6, 7, 5, deep pockets, it's like they're having very few pockets. It's sort of like all of a sudden the gingivitis is like clearing up. They're not having inflammation. And from that, they can see that this is the same thing that's going on in their heart. In other words, once they can see that rapamycin is stopping gingivitis, and they can see, oh, it's stopping the gingivitis, it's stopping chronic inflammation to coronary heart disease, and that's the same process. So that's why they can see that. Now the sort of stopping the disease is basically about lowering mTOR. the activity of the macrophages is driven by mTOR. If you lower mTOR, you lower the activity of the macrophages, you're preventing the disease. So my whole sort of like approach is lowering mTOR. mTOR was not discovered until 1991. So it's very, very new. It wasn't the role of mTOR in disease was not recognized till 2010. Since 2010, mTOR has been the biggest thing in the basic science laboratory, but it hasn't gotten into clinical medicine. Anyway, so my whole approach is lowering mTOR. The number one thing I use for lowering mTOR is rapamycin. mTOR is target of rapamycin. It was sort of like named from rapamycin. It was named, they discovered it because they discovered there was something that was being blocked by rapamycin. So TOR is target of rapamycin is blocked by rapamycin. So I use rapamycin to lower TOR. And I use it once a week because using it once a week, it's a safe drug. And using it daily, it's a toxic drug. And the other part of sort of like lowering mTOR is basically all sorts of lifestyle things that lower mTOR, which is mostly all about insulin resistance. Why it's about insulin resistance is insulin is the number one thing that increases mTOR. So if you have insulin resistance, you have a high level of insulin. The high level of insulin raises mTOR and drives the disease. The things that sort of like causes insulin resistance is number one, being overweight. So I try to treat everybody to have an ideal weight. And an ideal weight is basically about the same weight that you were when you were 25 years old.
Oops.
Or you can look at your waistline, like your waistline in men should be half of your height. If you're 5'10", your waistline should be 35 inches or less. So like if your waistline is not increased and you're sort of like waist and your weight is similar to the weight that you were when you were 25 years old, you're generally insulin sensitive. The problem is as people get older, they lose muscle mass, 2 or 3% of the muscle mass. So you should be weighing less, not weighing more. The problem is, as people get older, they tend to develop insulin resistance. The insulin resistance increases mTOR. The mTOR causes you to put on weight. So you're in a vicious cycle. You have sort of like, it's like insulin resistance, putting on weight, more insulin resistance. When you're like insulin resistance, it's very hard to lose weight. So the best way to break that cycle, you need rapamycin to reducing mTOR is the best way to break the cycle. If people and the problem is with gaining weight, some people gain weight, it has a slight effect on them, on their insulin resistance. An ideal insulin resistance score is 1.4 or less. So I measure insulin resistance with everybody. It's basically, I measure insulin, I measure glucose. From those two, you calculate insulin resistance. Insulin resistance, 1.4 is good. 2 is early insulin resistance. 3 is significant insulin resistance. Most people who gain some weight have insulin resistance levels around 2 or 2.5. But some people who gain weight develop a fatty liver. Now, if you have a fatty liver, you have a much more dramatic increase in your insulin resistance, and the number is likely to be 3 or 4 or 5. So whether gaining weight is associated with a fatty liver or not is just luck of the draw. Some people, they can gain weight and they don't develop a fatty liver, and they're okay. And some people, if they gained a little bit of weight, they develop a fatty liver, and they have a much more sort of serious problem with insulin resistance. The other part of sort of like treating insulin resistance is basically having a diet that's low in carbohydrates. As carbohydrates raise glucose and insulin. So the treatment is basically a low carbohydrate diet, exercise, because exercise increases your insulin sensitivity, not being overweight. All those things are basically all directed at the same thing. Low mTOR, in conjunction with lower mTOR pharmacological of rapamycin, low mTOR stopping the chronic inflammation driving coronary disease.
Dr. Green, how do you calculate that number, insulin resistance?
So like I calculate insulin resistance. Technically, somebody came up with a very, very good thing about 30 years ago. They called it HOMA IR score. The HOMA was just a setup term. It stands for Homeostatic Model Assessment of. So that was just HOMA. That was just the setup. The insulin resistance was if you multiply insulin and you multiply fasting insulin times fasting glucose, and then you divide by the magic number of 405. 405 just makes the right answer be 1. So if you multiply those two, or I could put it in a sort of like website that says home IR score. So on everybody, I calculate everybody's insulin resistance score. 1.4 or less is no good. 3 is a big problem. 2 is something to work on. So the treatment is basically, so the entire treatment is an mTOR-centric treatment approach. In other words, everything is aimed at lowering mTOR, and lowering mTOR is based on rapamycin, a low carbohydrate diet, not being overweight.
So I know this is getting a little off topic, but you measure before you treat someone, you measure obviously the insulin resistance. What determines whether you would refuse a patient? Why would you? Do you know what I'm saying? Some patients you say, no, you need to work on this insulin resistance and come back to me.
Why do I do what?
No, I know. I had a friend who saw you, Dr. Green, and her insulin was way out of whack. It was like 28 or something like that, her HOMA IR score, I think. And you said that she needed to go find out what was going on. Maybe she had a pancreatic, I don't know, called it like a...
That'd be very unusual. In other words, high insulin is like a pancreatic beta cell adenoma making insulin is like 1 out of 50,000 cases. The other sort of like all the other cases are not due to sort of like a beta cell adenoma. They're due to being overweight. But if
and you want to put those people on rapamycin.
There's an insulin like levels like 25 and 30, many is like wonder about an insulin over, but almost all the cases, it's like 99.99% is sort of like the reason for the insulin resistance is related to being overweight and the liver and things like that.
So you treat almost all of your patients if they have insulin resistance, you treat them with rapamycin as long as they don't have
the rapamycin cycle
insulinoma or something like that.
Right. So I'm trying to get everybody to be insulin sensitive. Basically, insulin sensitivity is the measure of good health. If your insulin sensitivity score is 1.4 or less, you're healthy. And if it's like 2.5, you have a problem. So that's the number one critical measure of people's good health is being insulin sensitive. It's for like insulin resistance is a continuum. It's like insulin resistance is with like synonymous with pre-diabetes. Pre-diabetes is insulin resistance. Diabetes is insulin resistance.
And so based on our whole topic discussion today about inflammation driving, or the macrophages and the inflammation driving the myocardial, heart attack, infarction. Insulin sensitivity is more important probably than having
Insulin,
lower LDL, for instance, or
all this reduces to mTOR. Insulin sensitivity means low mTOR. Low mTOR means low level of macrophage activity driving the disease. High mTOR is driving the disease. So whether you have stopping the inflammation is lowering mTOR by whatever means are necessary. And the means is like pharmacologically and lifestyle changes, of which the most important are not being overweight.
Mhm.
So do you see the most dramatic drops in insulin sensitivity among people that are really out of whack? Because my numbers are pretty good, and
I'm not noticing, I've only been on the rapamycin a couple of months. I'm not noticed, I've lost a couple pounds. I wasn't, really overweight to begin with. And my insulin sensitivity, I think, was pretty good. So
Not overweight at all. People who are not overweight in a perfect weight are not insulin resistant. They have generally have very good, not being overweight is synonymous with having excellent insulin sensitivity.
Dr. Green, I will say though, I've heard lots of discussions between endocrinologists and stuff like on other podcasts, and they say that is no longer true. You have skinny fat people. They're called skinny fat people. They are people who get no exercise. Probably, I'm guessing they just, sit around, but they're not overweight.
Well,
But they are not insulin sensitive. They coin the term skinny fat.
it's all different conditions. That's why you have to sort of see if somebody is insulin resistant or not insulin resistant. Some people might be making low levels of insulin. So there's type 1 diabetes and type 2 diabetes. People who are making low levels of insulin, which account for about 10% of cases of prediabetes, are just making low levels of insulin. About the other, more than 90% are making high levels of insulin and overweight. But you have to sort of measure, in order to sort of see what's going on, you have to look at fasting glucose, fasting insulin, and hemoglobin A1C. Then you can sort out whether the problem is type 1 diabetes or type 2 diabetes, insulin resistance, not insulin resistance, too much insulin, not enough insulin. You need those 3 measurements.
I know you need all those to really get the whole picture, but there are people who are at the proper weight who are insulin resistant.
Yeah, well, it's a case of their waistline and their hips. In other words, you should have a lot of muscle in your hips and your waistline. But if somebody has any degree of liver disease, they'll have a marked degree of insulin resistance regardless of what their weight is. So if they had any kind of liver disease, for whatever the reason, that liver disease will generally be associated with insulin resistance, regardless of whether they're overweight. So you can be insulin resistant because of your overweight, or it could be related to your liver.
And you can be skinny and have a horrible diet, just live on sugar all day.
The diet.
Yeah, you can eat a lot of carbohydrates and be skinny. You can eat sugar all day and be skinny. I'm just saying I've listened to endocrinologists discuss this, and I won't mention the podcast, but it's my other podcast I listen to a lot. They say it's a big problem these days with young people, 20 years old, lots of them. They're insulin resistant. They coin them as skinny fat.
They have what?
Probably because of the American diet. They
coin the phrase, these people are skinny fat.
Well, I would have to see what they're talking about and see what's going on with the person's insulin resistance levels and what's going on. Now, there's the question of people, in other words, there's a big difference between muscle and fat.
Right.
is very, very good. So the more muscle you have, the better. Being thin because you've lost muscle is a sign of bad health, like, chronic disease, people smoking, other sorts of chronic diseases, like, cancer. So, like, being thin because you've lost muscle, that's bad health. It's a whole.
Yeah, but these are college aged students, so they're young students, college aged. Were the people that they were talking about specifically having this problem with metabolic disease at a very young age without being overweight.
Well, you have to see what kind of metabolic disease they're talking about.
Okay, I'll send you a link to the podcasts because you'd have to listen to them. I can't, remember off the top of my head. It's been a long time.
Insulin levels. If you don't measure insulin levels, then you have no idea what's going on.
Well, these are endocrinologists, experts, so I'm sure they probably are measuring insulin levels.
Cardiologists don't measure insulin levels. They have zero idea what's going on with their patients. Without measuring insulin, you don't know anything whatsoever about how people stand. So that's that's a real problem with endocrinologists. They appear to have never heard of insulin, never heard of mTOR. And so they try to look at diseases if you have never heard of mTOR, you don't understand the role of mTOR, you don't understand the role of insulin, you don't understand what insulin and the reaction of that, you have no ability to understand anything whatsoever. So that's a big problem with endocrinologists. They almost never measure insulin and they have zero idea of what's going on.
Right now, they're just going to prescribe everybody the GLP-1 inhibitors, and those will lower mTOR, and everybody will live happily ever after, I guess. Because those things are going crazy, there's so many people on those now, which is, that's like like the Ozempic and Mounjaro, those drugs. They lower mTOR.
They're also causing a lot of problems in people with
Yeah,
muscle mass.
They could be, yeah.
Well, we should probably wrap it up, guys. It's time. It's
Yeah.
long.
The main thing I leave people with the idea is that they want to know their insulin sensitivity. You want to be insulin sensitive, and with the idea that with it being insulin sensitive and rapamycin, you could be preventing coronary disease.
And it all comes down to inflammation, like everything else, it seems.
Inflammation that's driving the disease is causing all the lesions, right? If you stop the inflammation, you're stopping the disease.
Mm-hmm.
Okay, anything else in closing, Dr. Green?
Okay, very, very good. All right, very good.
All right.
Okay.
Good night, everybody.
All right. Good night. Next time. Yep.
Did you stop the recording?
I'm stopping recording.
All right, guys.